you very much. Welcome to last but one module, which probably is the scariest part. We have been hearing about cybersecurity, ransomware, and whatnot. And there are a couple of questions in the chat box as well, which are about when is the final exams. Final exams will be immediately after the last module. It will consist of 20 true false questions and 30 multiple choice questions. All of them are covering all the 20 modules. We don't put any questions which are not covered by our speakers. So with this short introduction, I will hand over the next part of the presentation to one of the most eminent speakers, who is the CEO and Managing Director of Quantum Biosciences, Dr. Ravi Puvvala, who is going to take us through cybersecurity and privacy issues in the healthcare AI. And to moderate this session, we have Dr. Subhakar. Over to you, Dr. Ravi.
Thank you very much, Dr. Suresh. And thank you, National Board of Exams for Medical Sciences for this opportunity. And good evening, everyone. Today, I'm going to talk about cybersecurity and privacy in healthcare, more specifically related to AI. Because today, as we know, AI, ChatGPT is percolating into our daily life. And the responsibility of us as a professional, us as a medical doctor or a medical student, is much higher. We cannot delegate the problem to our IT department and say that this is an IT issue and me as a medical professional are not responsible for it. And today our job is to educate all of you and what you all should know in terms of the cybersecurity and privacy. And for that, I'm going to cover 5 core components, starting from understanding what is the patient data, why is the patient data more valuable and vulnerable, and also specific to risks associated with the patient data, but also specific to AI tools. We're also going to talk about privacy and anonymity. We're going to talk about the current governance and law that the Indian government has put together. And then, what are the, vendors and, that are available to solve some of these problems and where some of these gaps exist. A brief about myself. I'm a seasoned entrepreneur with multiple startups that I've done over the past 25 years. And recently, I've started a company called Quantum Biosciences, where we leverage AI as well as quantum sensing to do ultra early detection of any potential organ failure. So we are looking at how to leverage the data coming from the quantum sensors and use that as a predictive score so that we can give clinicians more information before the biomarkers form. Yeah, and because of this, we collect a lot of patient data, we do a lot of research data, and we ourselves as a startup implement many of these cybersecurity practices. And I would like to share our experiences and also my experience as the VP of cybersecurity in the automotive domain before I started this. So let's look at what is the risk associated with in the healthcare industry. When we think about clinical risk, we typically think about misdiagnosis or medication errors or some sort of a surgical complication, but we never realize that the category of risk um, that is associated with cybersecurity could also kill patients. So the numbers on this slide demonstrate what happens when there are breaches in the healthcare domain and how much when a cost of each such breach in the industry. And the reason it is like goes up to like almost $10 million is because the value of the patient data when it is associated with diagnosis, medication, their psychiatric history, and their genetic markers is a lot more valuable and also typical compared to any personal information like credit cards or email accounts. The shelf life of this data is much higher. it can go up to 13 years. And when there are attacks that happen, and the downtime for the hospitals could go on average up to 3 weeks. And these days, in the last 5 years, we have seen number of cybersecurity related crimes, whether it is related to ransomware or phishing or spoofing some medical records. And I'll talk about each one of those and how they're prominent in today's world. So when we look at the attack surfaces, just like how we come up with a plan on how to protect our own home, we look at how many doors exist, how do we put the locks to the doors, how many security cameras do I want to install, or what sort of mitigation mechanism I want to do, looking at planning my own home. So similarly, we look at the attack surfaces that are possible in the healthcare environment, and then look at what type of mitigations are possible. So the first type of attack, as Dr. Suresh has mentioned earlier, this is the most prominent one that hits the headlines. It is called the ransomware. It is just like kidnapping a person. What happens is a cybersecurity person comes in, and then they encrypt all your hospital records. And there is no way we can look at the data unless we have the key to it. And because they were able to get access to it, and because they were able to encrypt all your data, unless we pay the ransom, there is no way to go back to it. And when such incidents happen, the only way to recover for hospitals is to use their backup data, and then try to recover from it. And and these are the ones that really hit us hard, because it makes it a complete stall when that happens. The second type of attack is called the data exfiltration. This is the one that's quiet. So imagine, you kept your laptop open, somebody sneaks into your room, plugs in a USB, and it so happens that your login session was also open. They could copy a lot of the records from your hospital system into the USB. That's just a simple explanation of what exfiltration means. But there are many other sophisticated ways of how they can walk into the door physically or through electronically, and they have a way to steal all the records. And when such things happen, nobody would even notice it, because they are making a copy, and this will result into extortion or identity fraud. And the third type of attack is called the targeted phishing. This is usually, somebody sends a spam email, and you would think somebody sends a very carefully crafted email, as if it came from your supervisor or from your IT administrator, and you think it is a legitimate email. And when you click some of these emails, your credentials could be inadvertently being given to the cybersecurity hacker. And so that is one of the reasons why they really give a warning when you're opening some attachments. And the other type of attacks is the adversarial AI. So this is a bit more sophisticated, where they're trying to spoof the AI tools based on modifications either with the patient records or the images. So imagine if there is an MRI image, and if somebody is trying to toggle the pixels so that where there is supposed to be a tumor, the tumor doesn't exist, and so on. The next type of attack is the supply chain attack. This is essentially a vulnerability in your tools that you're using. It could be as simple as a bug in your Microsoft, PowerPoint presentation or a Word document. And if there are cybersecurity issues with those such tools, you inherit them into your process. And of course, nowadays, there are a lot of data that is either stored on the premise, like within the hospital environment, or in the cloud. And sometimes the administrators, fail to lock these, data that is configured in the cloud. And such misconfigurations by an administrator could put a lot of your data open in the public. So a lot of these issues that I mentioned, they rarely come along. They're typically one leads to the other. So this is the reason why it is very important to understand what is the cybersecurity posture of your clinic, and also the environment that you are used to. So when we look at healthcare data, as I mentioned earlier, this is uniquely valuable. And because it is valuable, there are more type of attacks. And today, thanks to many digital missions in India, Ayushman Bharat, everybody has an Ayushman Bharat ID. Every hospital is forced to put their records online, and that means that cybersecurity attackers have more places to go and more ways to extract this information. And sometimes some of these records that are extracted fetch a lot of value on the web, especially when it comes from a very rich demographic region, or if these records belong to politicians or sports people, or any famous personalities. And makes it, your reputation goes down. There's a lot of sensitivity associated with information that is very personal to somebody. So, when we look at the type of the threats, let's look at, we went to Trend Micro, who is the leading threat analysis security provider in the world, and they look at every vertical. And we've asked them to give us the most documented threats in the last 2 years. So, they talked about this DICOM exposure, where some of these imaging servers were set up with like no password or encryption. They ended up being publicly accessible. And in 2025 alone, this software called Agenda, ransomware, um, it was able to hit 445 different hospitals. That's roughly one every 20 hours. So, because of these AI assisted mechanisms, they were able to bypass a lot of the standard defenses. Today, just like going to Chat GPT and we are asking for a lot of recipes, there are mechanisms you can ask, where you are given recipes on how to conduct ransomware attacks and so on. Also, there are lots of AI vulnerabilities, security flaws that have been disclosed on many of the tools. And also, the attackers have looked at how to look at some sophisticated applications like the digital twins. So digital twin is a type of a software where it can simulate a patient's environment on the computer, like for example a tumor, and they can actually simulate what happens when the tumor is analyzed, and a potential treatment before the treatment is given to the patients. So these type of digital twins are becoming very popular. And now the cyber security attackers are able to steal a lot of the data, by impersonating as if they are the clinicians and so on. And a lot of times your security as good as the access controls that are being enforced. And many of the times by sending a spurious text message or other WhatsApp type of applications, people are able to reach out to the key administrators, and make them believe that message is coming from an authorized user, and get a lot of these access credentials. So, as I said, AI is being adopted on both sides. That means now attackers have no procurement cycles or government frameworks to slow them down. And AI is also being adopted very fastly by the hospitals too. So this type of an asymmetry is the big problem. So then we looked at, let's look at how these type of attacks are happening in India. So there were like three specific scenarios that we came across in the last few years. The most famous one that happened in 2022 with AIMS Delhi, where they got affected by but almost 40 million patient records have been exposed. And that is because this hospital did not spend enough infrastructure to upgrade their framework. And you know because of this attack, there were also similar attacks on facilities like ICMR. Typically what happens is the attackers try to use many types of brute force methodologies to figure out like if their firewall has been updated, or they look at like how well their infrastructure is. So, and similarly, one of the regional cancer centers got received a $100 million ransom demand following this ransomware attack, because it is a very large cancer center. And a lot of the framework, when we are dealing with a cancer patient, the type of the frame, this hospital cannot be have any downtime, because there are casualties associated with keeping the operations delayed. And so a lot of these type of ransomware attacks look at such ICU type of facilities, or very high profile frameworks where a time is of essence. And similarly, there was an attack on the health insurance agency, where a lot of the personal and the medical information of almost 30 million customers have been affected. And a lot of times what happens is, when this data gets extracted, this information can be used in various forms. They could be used for blackmailing somebody, they could be used for understanding the tax details, customer IDs. We really don't know where all the side effects that happen, because the information is lost from one place to another. So what can we do? So most data breaches in the healthcare, they don't start with the sophisticated hackers. They start with a clinician is on a personal phone, or you forgot to open the session on a forgot to close a session on their PC. And this is all about like us coming up with certain habits. So on the left, we try to capture these habits that we should feel as automatic as our hand hygiene. So some of the frameworks that we talk about is, you always use your hospital approved devices, you lock your screen when you step away. If you lose a phone, you have to report within the hour, not at the end of your shift. And leverage two-factor authentication whenever it is possible, because you want to treat this the same way you are trying to check a patient's allergy status before prescribing some medicine. It is having these cybersecurity habits is as important. One of the things that I want to highlight, which we will talk about, is the upcoming the DPDP Act. Any delay in reporting such events may cause huge fines to the clinic that you're working for. And this law has been put up but 2 years ago, and it is going to be enforced from next year. So a lot of hospitals are looking at how to comply to the DPDP Act. And having these type of habits, as I have mentioned, into your daily practice will really help you to not only reduce your personal liability, but also the liability to the hospital that you're working for. On the right, we talk about we try to mean good, but sometimes we try to do it for the ease of convenience, especially to use tools like WhatsApp, to exchange patient information. We think it is all naive, but at the end of the day, you are putting some data that is not part of your institution's control, and you could be causing a breach, simply because your IT department did not approve the usage of WhatsApp. And similarly, there are lots of free applications and free tools that people try to prescribe, people try to recommend. And once you are recommending, the you don't know how these free tools are misusing or using the patient's information. So as I talk about throughout the presentation, I want you to think about these like the underlying standards or laws that are associated with it. Where we have the HIPAA, we have the India's DPDP Act, and then we have the cyber hygiene guidance from the NHS. All of these, they converge on the same principle, that clinician behavior is the biggest variable in data security, and policy can technology can only do so much. It really, the rest is all about the habits that we have and how we are incorporating into our daily life. So far we've talked about like the type of the data, the type of the framework, what is patient data, how type of attacks are possible, and how to protect from the perspective of a clinician and the perspective of the clinic as well. So now we will talk about like something that are related to the AI, you know, because we are all starting to look at AI, and sometimes it is good to use AI, but there are certain, fallback mechanisms that you want to keep in, keep in mind. So as we shift the focus, because as AI is become embedded in the clinical decision making, especially with like diagnostics, prescribing, risk stratification, and documentation, this is the category of risk that didn't exist before. So now there are so many new types of threats that are very specific to AI. The first one is the data poisoning. What happens is AI model is only as trustworthy as the data it was trained on. So if in adversaries inject manipulated samples during the training, the model learns the wrong patients silently, and the risk stratification tool might consistently underflag for a patient profile, and nobody even knows that that type of bias has already been built in. And the second type of attack is the model inversion. The attacker doesn't need to break into your database, but by querying your deployed model, like just asking questions from the model, they can analyze how, that engine has been trained with the training data, and they can reverse engineer. And sometimes they could even reverse engineer, that about lots of queries on the type of patients that it was trained on without even touching the actual database of the, hospital. And of course, with the, if we have poor access control, sometimes, AI systems don't enforce granular or role based access. Like for example, if the same AI tool is giving same information or detailed information that only the surgeon is supposed to see, and maybe the pharmacist not supposed to see some of that information. And sometimes, without this, poor access control and ensuring don't give out information that is not needed for that role, there is a potential for leak of information. And most importantly, what we need to ensure is that there is an audit trail. So when an AI assisted clinical decision causes harm, we don't have a way to like say, hey, we can't just go and blame AI told me so or chat GPT told me so, right? We need to find a way to document it, to say, okay, you made this decision based on the chat GPT output, but your analysis or your training as a doctor or has is telling something, much different. So one of you is wrong, which means you need to flag it and you need to document it so that you can understand maybe the model got trained differently, maybe you have made a mistake in terms of your understanding. So these type of mechanisms to ensure there are logs both from the tool and both from your decision making process would help us everyone to keep things in check. And then there are, of course, the supply chain attacks that I have talked about, depending on the tool. Let's say if everybody is using Cloud or Chat GPT, or Gemini, any such tools or cybersecurity framework that these tools are inheriting, you're also inheriting a lot of these mechanisms. Sometimes, your hospital may not have, given you the authorization to use these public domain AI tools. And when you are putting some of the information for you to query, you are inadvertently giving your patient's information to these tools, and that could be, used in a very different way. So as I said, unlike the conventional breaches, these type of attacks, they won't leave any trace, and that is the reason why we need to be a lot more careful. So I want to give some examples of these AI specific attacks. So in this left side, there is a specific framework where the attackers were able to flip a single pixel in a medical image. That was enough to flip this high risk patient to the low risk. And because there is no visible alteration, just when the clinic had to see it, when the clinician had to see it, he had to give a wrong output because he had no idea that image got tampered. So just to look at from a context of India, AI-based chest X-ray tools are currently deployed across almost 500 hospitals and imaging centers. including like 400 mobile vans that are operating in remote areas without internet connectivity. So what happens, imagine like there is a mobile van going into certain, remote area, and they are using this type of AI tools. And sometimes because of this type of bugs, though they were supposed to qualify if like some of the patients based on these x-rays, if they have TB or not. And because of these type of bugs that are inherited into these tools, it will give you wrong output. So it is very important to understand what type of attacks have happened and how that we need to map it to the Indian context and understand how to protect against it. The right side one, talk about the model inversion, where there are lots of facial features that are reconstructed from the brain MRI or the AI models without accessing the original scans. So the model itself was like the lead, as the same vulnerability applies to retinal dermatology. um, you know the basically what we are trying to showcase here is that, like how the forensic people use a lot of the information from the dental scans or other type of mechanism to identify who the person is, the AI could also reverse engineer just based on the images. They can identify who the patient is, and that information could inadvertently be used in other mechanisms. A lot of times we think, hey, we are masquerading the patient name, but it's okay to just share the image or the patient records. But there are ways to deconstruct the patient information just based on their MRI scans or dental images. So this is where the privacy laws come into play. As the AI models are AI tools are getting deployed a lot faster than the regulatory framework that can catch up with it. So we need to really understand how to trust these tools. So we have looked at a framework of, you as a clinician or you as a medical student, you need to ask these questions before you can trust any clinical AI. So the questions that we want to teach you to ask is to, each one of these questions maps to a specific failure mode that I have talked about. So you want to ask, if your hospital is recommending you to use a particular tool. Let's say this is coming from NVIDIA, and they have a radiologist tool, and you want to understand who trained this model. This is not a technical question, it's a clinical governance. So just like you as a doctor, you won't prescribe a drug without understanding to what population this drug has been used, right? You would not say like, okay, this drug has been prescribed for to solve this medical problem, but you really want to understand, has it been tested on the local population? So just like that, the same logic applies here to AI as well. So if a diagnostic AI tool has been prescribed, we want to understand, has it been trained on the Indian patient populations? And has it really understood different disease prevalences that are more specific to the local area? What are the characteristics? And most importantly, our CDSCO now classifies AI based diagnostic software as a classy medical device, and we want to understand, have they got such clearance in India? And if their answer is no, then it is very simple, you don't want to use it. You want to make sure that any tool that is being recommended to you is actually approved by the local authorities. Again, you also want to understand, has a role based access been enforced? As we discussed, when looking at the poor access control, the risk is not always external. um, a pharmacist who can view the oncological predictions or a junior resident who can access psychiatric risk score represents a governance failure. It is not a malicious. So before using any tool, you confirm that it only shows what is relevant to your clinical role. If it doesn't, then you want to flag it to your IT team, adopting it into your workflow. And most importantly, you want to understand, have these audit logs been active? Because in India, as part of this DPDP Act, it creates accountability obligations on how personal health data is accessed and processed. So if an AI assisted decision causes harm, and there is no log of who queried the system and when it was used, we can't just say it is an IT problem. You really want to be part of the loop, because that is part of your clinical workflow. And of course, the most important thing is you want to understand, as your institute or clinic has approved such a tool, and you also want to report if there is an anomalous behavior, because a lot of times a recommendation doesn't fit your education, or doesn't fit your intuition. You really want to understand who's wrong, and why there is a discrepancy. And as I said, the discrepancy could be on either side. We cannot completely blind what the tool is recommending. And we also need to be knowledgeable enough to ask the right queries to make sure the decision that you have made and what the AI tool is recommending are aligning. And if it's not aligning, you want to know why. And also, shared logins, or this becomes a bigger issue, to make sure that, imagine if everybody is using the same AI tool with the same login ID, there is no accountability of like who's querying it, who's using that information. And the hospital will have a very tough time trying to figure out how to enforce auditability, and enforce how effective the tool is. Okay. So all of this is not bureaucratic. It is the minimum viable framework for clinical accountability, especially when AI is in the loop. And as India is scaling, the digital health infrastructure through Ayushman Bharat and India AI mission, these check boxes and these questions are very important to make sure that we are deploying AI responsibly. And here is a phrase that constantly appears in data sharing mechanism. That means, if I have removed the customer name, it means that we have de-identified their information. So just removing a name does not create anonymity. So there are a lot of this information where it shows that, just based on the date of birth, whether the person is a male or a female, and the pin code alone, they can reconstruct a lot more information. And today there are like multiple registry databases that we have. Somebody can go query the ABA based on the ABA ID, they can query based on the Aadhaar ID, or they can query based on your date of birth. And there are many registries that exist, public registries. They can use that information, and also the partial information that they're able to extract and figure out. So we have to be really careful about understanding that just removing the name, or the customer name, or the patient name is not sufficient to say that we have de-risked, or we have de-identified that particular patient. um, as I talked about, you can reconstruct based on the imaging data, you can reconstruct based on the genomic data. There are lots and lots of variations of reconstruction or re-identification that is possible based on just partial information of the patient, or the information of the patient data, just like their health records or the imaging mechanism. So again, here we talked about some specific scenarios of how, based on this de-identification information, like somebody went to were able to use the dental records, and they were able to re-identify the patient, and somebody was able to query the public cancer registries, and were able to re-identify the patient. It doesn't mean that we want to we can think that by just removing the name that the patient records are safe. Okay, so far we have shown that the de-identification fails in practice. And so there are like simple rules that we adopt. We say data minimization is the foundation. Every variable we add into the data set multiplies the identification risk. Look at the consent scope. Even though our intentions are good, sometimes we fall short. And especially when it comes to privacy, we think by just taking a consent from the patient about the treatment is sufficient, that it will cover lots of other types of research. Today, according to the DPDP Act, we have to make sure that we take the consent of the patient, not just for the patient outcome. We also have to ensure, take their approval, that this information is going to be used by some AI tool, that this information is going to be used by other types of research. So these type of explicit consents are very important. And we want to make sure, like as I talked about, these images, or the health records, or MRIs or OPGs or retinal information, or your dental scans or dermatology scans, any of them can be used as biometrics. And sometimes a combination of these would play a much bigger role. So now let's come to the crux of our liability and the law that the Indian government puts in, right? This is that DPDP Act, and as I've talked about, it is going to be active as of next year. It is going to be enforced. The act came into 2023, but it hasn't been enforced, and now from next year it will be enforceable law, and it binds every clinician, researcher, institution that handles patient data. So these are the 6 obligations you want to know as a clinician. Data principal rights means your patients have the right to access, correct, erase, and port their data. So if a tool that is recommended to you does not give option for the patient to go and delete their information, that means you are violating the patient's right. So any tool, so these are also the questions that you should ask when you're incorporating the tool, or when you're taking the consent from the patient. The patient should know how to make sure wherever these records are being stored, that they have an ability to go and delete them if they don't want to have it. And without giving such explicit control, you will be violating the patient's rights. And that means that there will be a lot of fines associated with you or with your hospital. And also we want to make sure there is a consent driven processing. That means the obligation that reshapes how we do our research practice. As I've talked about, the treatment consent doesn't cover the AI based training. We need to make sure that the consent forms that we are filling, having the patients to fill in, also covers your clinical the workflow. And that if these workflows are incorporating AI tools, and your consent forms need to cover that framework as well. And then the fiduciary duties, right? It means that the hospital bears the primary accountability. They no longer can say it's a third party AI vendor that did the breach, and you cannot contract away that liability. And you need to make sure there are proper vendor agreements that are in place, so that the vendors are also they're doing their job to protect the institution under this act. And the most important one that I really want to emphasize today is this 72-hour breach reporting. And this is unambiguous. When you find an issue, if you wait more than 72 hours, that means you are committing a fault. You are violating the DPDP Act. And the type of the fines associated with, like, just delaying the breach reporting is going to be a lot higher. And as I talked about this purpose limitation, make sure that the data collected cannot be repurposed for other types of mechanisms unless with explicit content. And also, most importantly, these days, the data has to stay within the boundaries of the India borders. So any tool or any vendor cannot take the data out of the country, and they cannot be hosting in Sri Lanka, or they cannot be hosting this data in Nepal or USA or anywhere else. So you want to make sure that your vendor, or your where the information physically, the data lies. And especially when this data is associated with children, the restrictions and protections are even more severe. And as you can imagine, any violation of the children's data could be extremely sensitive. So as I really want to emphasize, the penalties that can go up to 250 crores, that means a simple mistakes or ignorance by the staff could bring down the entire organization. And this could be easily preventable based on how we develop our habits. So previously we outlined what this DPDP Act requires. Here we talk about the requirements when these type of frameworks are ignored, how these type of governance gaps end up in courts. Like in the US, Epic is a tool that manages the health records. 70% of the hospitals use this Epic tool. And this, they had a mechanism to detect. They also were incorporating early detection, and they had a mechanism to detect early detection of sepsis in the ICU type of scenarios. And the way they trained the tool had actually completely missed 67% of the real sepsis cases. And that is because the hospital or the governing body did not ask them how they trained that particular tool, under what population they have trained the tool. And because of these kind of biases and shortcomings that they did not identify before they have adopted the tool, they ended up being in the court, and they ended up paying lots of huge fines. And the same way on this right side here, a lot of this data was disclosed as part of the commercial drug interaction, and the pharma companies were erroneously able to get a lot of the safety signal, deep information that they did not get that with the explicit consent of the patient. And when they've identified that the pharma is able to extract this information, and when they have seen that the patients have not given explicit approval that their information can be shared with the pharma, they ended up in the court. So what I'm trying to say is that when a clinical workflow exists in your organization, make sure you understand as your role. You could be a pharmacist and you're using this tool, and you may be inadvertently giving this to the pharma company. So the question you should ask is, hey, have you got the right consent from the patients? Are we allowed to give this information to the pharma company? So just by doing such a simple query to your clinic, you are able to save your organization from future getting a lot of fines being levied on them. So the whole part of this webinar is to make sure that you understand your responsibilities and you're able to query. Okay, so we've covered the law, and we have seen what the governance failures look like. And simple things that, just like the habitual process that I would talk about, is get the specific AI consent. You document every AI assisted decision. Most importantly, your fiduciary duty based on your role. And this is, I cannot emphasize how important this is for you to understand. As I said, what is the act, and what is your accountability, and what happens if you're not asking the right questions to your institution. And make sure you're escalating these breaches, and make sure you read your hospital's AI policy. And you have to challenge the framework. You have to understand, if you see an issue, how can, if there is an escalation pathway. And as we are adopting these new tools, as we are incorporating this as part of our workflow, you asking the right questions, you're not only creating a very good diligence, but also you're protecting yourself as well as your institution. AI suggested can never be a legal defense. You have to know that you are the one who is using that information, and you are the one who's making an act. You really don't want AI to make decision on your behalf and tell the patient to go into surgery without your explicit approval. So a lot of these type of processes that you want to question, and there are no automated decisions that are being made without explicit approvals. So again, different type of settings causes different exposures. If you're a public hospital, typically you face an infrastructure problem. Maybe you're having a legacy operating system, and the exposure level is a little different. If you belong to a private hospital, there are a lot of premium data, and that attracts premium attackers. And because private patient records carry rich demographic and financial information, that makes them more valuable. Again, if you look at, you're working with startups and the cloud deployments, yeah, as I've talked about, a simple error by your admin to not have the proper information or proper security keys for the information that's stored in the cloud could cause a lot of embarrassment and a lot of credibility loss. And once the credibility is lost because of such misconfiguration errors, it will take years to reconstruct your reputation in the industry. So a lot of that we want to, if you are in the administrative role, if you are the managing director of your clinic, you really want to demand the proof of the ISO certifications, the SOC compliance from your vendors, and also from your own IT infrastructure. In fact, sometimes in our industry, we hire professional hackers to actually attack our own infrastructure to see whether this type of penetration, during this type of penetration testing, we are able to assess our own vulnerabilities. So essentially we can create such mechanisms and make sure that these type of tools and people are available, and leverage that to ensure that you have built a robust infrastructure. Here we just wanted to talk about what happens when there are vendor failures, and that becomes the patient failures. Here we've talked about some of the biases that existed in the case of the oncology AI tool, where the vendor algorithm has a completely different bias, and what happens when you have you know um, uh, misconfigured your public infrastructure framework. So again, when you are like asking a lot of these I've this is the last component that where we talk about the vendor gaps. When you are like looking at what vendors, you really want to understand where is the patient data stored. As I've talked about the DPDP Act, data must reside within India. No overseas transfer without explicit patient consent or government approval is allowed. And then what you want to understand, what type of encryption is used. You want to make sure that they are using the most advanced encryption. Is your vendor certified for ISO? We talked about the SOC compliance. Who owns the models of the patient data? What is the service level agreement when you have notified a breach? And most importantly, has there been an audit in place? And I've talked about the use of penetration testing or other type of mechanism. And because there is so much money that is spent into building such robust infrastructure, if there is a AI tool that cannot answer all of these questions, that means you are putting this patient data at risk. Don't use it. So you really want to make sure that whether it is free or paid, that these questions are well understood. And when we have identified such mechanisms, there is no transparency on what type of training data has been used to build such model. If there are no audit logs, and if there is no clear understanding of where the backend is, where they're trying to store the data within the country or outside the country. And sometimes there are a lot of clinical assessments, there are a lot of contradictions between your clinical assessment and what the AI is giving you. And sometimes maybe it is trying to bias to say that everything is too good to be true. Like sometimes it's over fits the model by catastrophically trying to look at the clinical settings and says, based on the population type and based on the age, maybe it is making certain decisions which is not supposed to, right? So it is very, very important to, when in doubt, don't use it. When in doubt, document your concern and make sure you're able to escalate it. And you have your clinical judgment always takes precedence over what the AI is recommending. So again, as I've talked about, the 6 principles for safe clinical guardrails is that you always want to have the human in the loop. You want to make sure that the clinician is the one deciding, not AI making a recommendation about like whether they need to go to surgery or not, or whether to go to the next level of treatment. And always cross check the AI output, and always make sure that you know that you are using the tools or the frameworks based on what your institution has approved, not based on what your peers have recommended or what your friends or what you have seen on the social media as a better way of you leveraging the information. This is why it is important to have a cybersecurity posture at the institution level, and that the institution has an AI policy. And as I said, to protect your own self, you document everything, and you have an escalation protocol, and make sure that any tool that you're using is not biasing based on their income level, based on their age, or based on any such parameters, where it might be giving fraudulent output. So we have covered a lot of ground, but I finally just want to make sure that based on whatever department that you are working on, that you have something to take away. If you're in the gynecology, you know you want to make sure that you always keep the manual CTG protocols active and practiced. And there are a lot of information about reproductive data that carries the highest legal sensitivity under the DPTP Act. There are a lot of consents that must be explicit, documented, and purpose specific. And as I've talked about, even the obstetric scans and CTG traces must never leave institutional systems. As we know about a lot of the genocides that happens based on the information that gets leaked, on the um, to understand the sex of the baby. And a lot of this information is very sensitive, and there are lots of very strict rules that this information cannot be revealed. So very important to understand, like, these information or these scans are not going onto your personal devices. And sometimes that from your personal devices there is a higher chance of going into the public domain. And of course, if you're in the general medicine, as I said, any of the tools that are doing early detection, you really want to understand how the tool has been trained, especially about the patient data. You really want to make sure that you're not incorporating a tool that's trained on the Western population. And understanding the framework of what population data that it has been trained on. And if you're working in general surgery, as I've talked about this, you have to understand the possibility of these AI adversarial attacks, especially when you're relying information on the digital MRIs or digital X-rays. You want to double check a physical version as well as the digital copy, just to make sure there are a good ways to counter if something that you need to be able to understand that there are such possibilities, and you want to make sure that you looking at the right information. And if you're in the robotic surgery, surgeon accountability is absolute. That is another reason why you want to make sure that when you're using a surgical robotic system, that you're able to document these intra-operation AI alerts, and make sure that you're making your decision based on an audit log mechanism, that you have the proof on where you are in control, where the machine is in control, and so on. And you really want to make sure that there is an audit log that's generated after the surgery is complete. Same thing happens when if you're in the dental surgery. As I've talked about, a lot of re-identification that can happen based on the images. So you want to be really careful about how the data leaves your institutional framework. And I've talked about the pharmacy scenario. You really want to make sure that there is consent, especially if the data is being exposed to the pharma company, that a general patient consent for the treatment does not cover that data to be shared with third party vendors like the pharma company. So these are the things that you want to remember and enforce when you go back into your hospital. And if you work in the oncology and the radiology, and I've talked about some of the biases that exist. And and as I've talked about, like, as you're incorporating new tools, as you're incorporating new type of applications, you want to make sure that there is consent from the patient to be able to allow to use this tool as part of the research purposes. So these type of explicit consents are very important to protect privacy. And understanding some of the vulnerabilities that may exist with the AI tools is also very important. And this is my last slide. I just want to make sure that there is a final takeaway. This accurate AI plus a data leak is still a failure. That means the clinical performance and the data security are not separate concerns. They are the same. And a model that works perfectly but exposes the patient data means that they have failed. So privacy breach means you put the patient at harm. It's not a compliance issue, it's a reputational issue. And as I've talked about, the trust once lost is irreversible. We have looked at the scenarios of the popular hospitals, infrastructures, what happened when they have not spent enough money on upgrading their IT infrastructure. And clinician awareness is the first line of defense, not the IT. We can't put the responsibility on the IT or the procurement and not the vendor. It is you, because you are the person at the point of use making the decision to adapt, recommend, uh, or else if you don't think your training is in compliance with what the AI recommendation is, you really want to challenge the AI tool. So infrastructure choices set the ceiling. So the best clinical AI judgment cannot compensate for a misconfigured cloud configuration or a legacy operating system or a vendor contract. See, AI will not replace clinicians, but clinicians who understand AI risk will replace those who don't. And I hope I was able to drill that very well. And thank you so much for your time.
Wonderful, sir. I mean, this is probably one of the best lectures that covers about the most important things in life. You can stop the presentation, sir. There are 4,800 comments in the chat box, out of which close to 600 are relevant, and minus the pricing and what the wonderful lectures out of the close to 200 questions are there.
Okay.
Subhakar, it's a very huge task for you to sum up and then moderate with Ravi.
Yeah. So very good, Ravi. I think pretty much you have covered the entire depth and breadth, and then a lot of feedback came, and then very insightful questions. The first question I'll start with is, a lot of hype about MITAS, and then how do you suggest, protect, or maybe what kind of advice do you give to the doctors and clinicians to protect themselves from these hype and around these MITAS?
Whether it is Mythos or Claude or anything, I think the tools are as good as the questions that you ask, right? Because at the end of the day, when you ask the right questions, if it is giving you certain output, you really want to go back and question, you want to go back and ask the assumptions that the tool has made to come up with the decision. So I think there is a lot of good query mechanism. There's definitely a lot more in-depth analysis that the AI, all of these tools are providing. But I think it is important to understand the basis of the decision. And you as an expert, you as a clinician have the training, and you really want to make sure that your judgment is in compliance. There are certain things that the tool is teaching, but at the same time that there are certain things that the intuition is also teaching you. So my biggest advice is use it to your advantage, just like how we use calculators, in our daily life.
Okay, good. So the next question is there a way to check the vendor's authenticity and genuinity when they sell the AI products as a software? What kind of recommendations do you give?
So I said the CDSEO, right? Because today a lot of vendors are coming up with AI tools, and the software as a medical device, as a diagnostic medical device, should be approved by CDSEO, right? And I think maybe there are a lot of tools that are making recommendations. Maybe there are a lot of tools that are giving early, predictions, but you need to have a regulatory framework, a regulatory approval in order that needs to go into your workflow. Unless there is a third party regulatory that has approved it, you don't want to use it, no matter how good it is.
So part of the implementation for the DPDP Act, what sort of recommendations do you give for the especially while you're collecting the patient's data and using the old patient's data for the training the AI model?
As I said, just because the patient have given consent in the past for making sure they can use the treatment outcome is not sufficient to go with the new AI world. The DPDP Act says those are no longer valid. Though you may have million patient records based on the previous consents, now you have to go back and re-get the consents from the same set of patients in order to use the AI infrastructure. So that is part of the compliance and enforcement. That is why I keep talking about the scope of the consent. And I think our old consent agreements did not cover many of these scenarios. So essentially what happens is, from next year, all of the data records that we have, if we don't have the right consent from the patients to cover it, we need to go back. We cannot use that information anymore.
Right, right. So a lot of times lab reports are shared by patients in a WhatsApp for analysis and do the treatment and advice and other thing. In these scenarios, what is your recommendation or a suggestion to avoid breaches and be compliant to the DPDP Act?
As I said, WhatsApp is typically not covered by your institutional framework. And because your institution has no control of a private conversation of a WhatsApp between a clinician or a pharmacist or anybody that who works in a hospital environment to the patient, they are going to be breach the DPDP Act. And inadvertently, once the government starts enforcing this, there will be a lot of fines associated with it. And as I said, this is a lot of patient information is very secure. And then especially depending on the patient who he is or who that person is, and um, if that information gets inadvertently leaked, that causes a lot of harm not only to the patient but also to the hospital too. There is a big reputation at risk. So my advice is never use WhatsApp to receive patient information or exchange. And I know this is happening a lot. um, One mechanism that I could recommend is to maybe set up a policy, at least at the minimum, where the messages get disappeared within 24 hours. At least do that as a mechanism to say, okay, you've seen it, maybe you are like, I'm trying to minimize the damage, but even that is not recommended under the DPDP Act.
Right, right. So as a follow-up, a lot of these reports gets used to train the AI models, but there may be some sort of mechanism between the when the vendor is trying to come to sell that I have the highest level of accuracy because I've trained on the trusted data. But how do you verify whether it has been trained on the trusted data, or the data is being scrapped from the Google and then used to train that model? How as a practitioner should what sort of mechanisms to incorporate to really try which one is being used to train the model?
I think as I gave the pharmacy example. As we want to know before the medicine is prescribed, we want to understand if that has been tried on the local population. Similarly, we need to have reports from the vendors that are selling these tools that it has been trained on the local data. There has to be a certified report. And I have to go back and look at the guidelines to say, where, how do these reports, which is one of the reasons why I go back to CDSCO, and unless it is approved by the CDSCO, and they would probably ensure that one of the criteria for approving this is that it is being trained on the local population. So the first line of defense is the CDSCO approval. Second line of defense would be to get these, training data from these vendors directly.
Got it. So as a last or maybe a last couple of questions. So what happens to the data when it goes to an insurance claims, and who then bears the responsibility for data leakage?
The insurance company also has to follow the DPDP Act, and they have to ensure that data is not going outside of their institutional organization. And that is also the reason why even within the the health insurance approval policy, there has to be role based access control, that people are only seeing information that is relevant based on what they're trying to approve. And I think we still have a long way to go in terms of having that level of granular access and making these type of enforcements in place. But I think this DPDP Act is the starting point in terms of how we protect, how the data not only leaves the hospital environment or the health insurance company, but also not the country. Imagine what the pharma companies can do if this data is leaked. The Indian population, um, whether it is health related or other type of information, it is very sensitive information, and we really want to be able to protect these type of mechanisms within the country. Just like we are seeing a lot of outbreaks based on Hanta virus, Ebola virus, and so we really, a lot of this information could be used against us in terms of future type of virus outbreaks.
So that's great. We are coming to the end of it because 15 minutes of the moderation is over. Any last question, Subhakar? Before we wrap up the session, then hand it over.
So last one or two questions is any practical implementation tips for the defend against AI risks?
As I've talked about, first thing is it needs to comply with your own judgment, and you want to make sure that is the reason why we have basically asked these 6 questions before adopting an AI tool. And I think hopefully we can share the slides and they can go back and look at the recording. But asking these questions and incorporating as part of their workflow is very important.
Got it, Ravi. I think any leaving thoughts, as a best practices?
As I said, AI is not replacing clinicians. Clinicians have a very, very important role. But the clinicians who don't understand these risks, right, will be replaced by the ones that they do. Because if a simple error by clinician, you are causing a huge potential fine to your organization. And that's why I'm really glad NBEMS is doing a lot of the investment into training our upcoming doctors and existing clinicians, because it is as important as any other technology or tool. We need to understand our fiduciary duty.
Well said, Ravi. Yeah, I think Dr. Suresh, we have covered the gist of all the questions.
Absolutely, a lot of questions were there. I mean, thanks, Subhakar. It's not easy to some of them. A lot of questions were there. And for your information, all these videos are available online. You can just watch them. And the mail IDs of most of the speakers and moderators are available. So in case you really want to reach out to them for a genuine thing, we can explore on how best to assist you people. Because I've been hearing can I get the phone numbers? Usually I don't prefer to give phone numbers of either speaker or moderator, but mail, probably you can just try, and please try not to spam and bother them. And over to NBEMS for the conclusion.
Thank you all for joining this session. Thank you. Thank you, sir.
Thank you, sir. Thank you for the opportunity.
Thank you. Thank you.
Thank you, Subhakar, for wonderful moderation as well.
Thank you.